Okay, and the third bias that we'll talk about, and I'm just going to check the time here real quick. Okay, the third bias that we're going to talk about is confirmatory bias. This is huge in medicine. It's huge in lots of different fields, but I think particularly in medicine. It's our tendency to prefer information or even search for information that's consistent with what we already think or what we want. So it can come from two sources. It can just be we believe certain things, and so we seek out or believe information that fits with that. It could be that we're motivated. We have a certain desire to see things in a certain way, because sometimes both are happening at the same time. And so the thing with confirmatory bias is that it happens earlier in the decision making when we're gathering and interpreting information. In your work, it's when you start asking the patients questions, right? That's where confirmatory bias is. It's not at the point where you're making a diagnosis. It's when you start asking questions. So let's imagine that a patient comes to you and you've been doing this for a while and you have some expertise, and you look at some deadened affect, you look at the posture, how the person says their first couple of sentences when you say, "What brought you here today?" And you already have a hypothesis that this person's depressed. You already have that expectation. And there's probably no way to keep that from happening. That's not going to be a remedy for this, is try not to have expectations, because it's good to have expectations and you're not going to be able to stop them, right? So, but what you might then do is tend to ask questions that are more likely to get the answer of that supports depression. So you might ask about sleeping patterns or eating patterns or crying, or you kind of have a checklist in your mind, and you might start with those. And a critical thing is, because there's so much overlapping symptomology in mental illness, is if you get affirmative answers to, are you having trouble sleeping, are you having trouble eating? If you get affirmative answers to those, what you're likely to do is see that as confirming your initial hypothesis, when actually it could be indicating something completely different. This probably doesn't happen as much in psychiatry, but research on doctors suggests that when you go to a doctor and they say, "What brought you here today?" you have 16 seconds on average before you're going to get interrupted. Right? And what do you get interrupted with? Probably, it's not that the doctor doesn't want a listener is unconcerned. No, they have already started to develop a hypothesis, so they have a burning question for you, right? And so they're going to ask it. And if you'd been, and then your answer to that, and you go off here, and it turns out that maybe the real answer is here, the real problem is here. And if you'd been allowed to talk for 10 more seconds, you would have said something that was over there, right? So as patients, a key learning here is figure out in that first 16 seconds everything you want to get across. But as doctors, it means stop and listen a little bit longer. So what we tend to do is search for information that confirms our expectations or our desires. We give more weight and credibility to confirmatory information. So if you read a journal article that says that what you've been doing already, or a treatment that you've been using, or a medication that you've been using is great, you're going to see that journal article is really smart. The person who wrote that is really smart. This is a great journal. You're going to interpret it all as a way that you should take this journal article very seriously. What happens if you favor a certain medication and you read the journal article that says the other one is best? Right? Then it's like, yeah, well, who are these guys? Yeah, well, this is a pretty good journal, but sometimes they let some crap in. You'll be much more likely to question it. And it doesn't mean you won't ever change your mind. We do sometimes learn new things and change our mind about things. But what is more likely to happen is that you'll wait and and see as valuable the information that fits with what you think. Same thing when you're interviewing a patient, when you're talking to a patient. So if you have a hypothesis going and you say, well, are you having trouble sleeping? There, no, my sleeping's been the same as it's always been. You might then tell yourself, well, you know, depression's a constellation of symptoms, and some people don't have that symptom. Right? That lets you keep going with your hypothesis, as opposed to, well, maybe I need to rethink. So with confirmatory bias, we also remember. So when we go to write our notes at the end of the day or at the end of the session, we're going to tend to have remembered the stuff that fits more, which doesn't mean if someone does something clearly and really counter to what we believe, that gets our attention. It's just within the realm of gray, we will tend to interpret it in line with what we think. And this last one is the really, really tough one about confirmatory bias. And particularly when we're judging other people. Most of human behavior is ambiguous. Many symptoms are somewhat ambiguous. What does it mean when someone says this or does this? You pass a colleague in the hall and they give you kind of a hello, you know, and you're thinking, what does it mean? Are they mad at me? Were they busy? You know, things are always open to interpretation, right? But what confirmatory bias does is it helps us out. Instead of being stuck all the time, we use our expectations, we use our stereotypes, which are basically a set of expectations. And these guide, you know, kind of tell us what's going on. But unfortunately, that also keeps us from noticing information that's completely counter to what we already know or what we already think. And so we'll tend to interpret ambiguous information as confirmatory. I remember when I was 20, I was a soccer player, still am, still play a couple days a week. I used to care about how well I played. Now I just care that I'm playing. At 55, it's like, I'm still here, yay. I still get to pass the ball, oh boy. But, you know, I was pretty serious when I was 20, and I was goalkeeping and landed on my side and was in phenomenal pain, just tremendous pain. Went to the hospital. They were quite sure I had torn an adductor muscle, right? Which was a very logical and reasonable thing for them to think, given that I was in a soccer uniform and had just come. They took an x-ray back, this is the 80s, so no MRIs, just did the muscle pull some bone off of the bone. So they look at the pubic ramus where the adductor attaches, and they look to see if the edge of the bone is smooth. And it is. So I said, well, so now there's no x-ray evidence that it's a groin pull, but I still think it is, which again, not an unreasonable diagnosis. You usually are not going to see that on an x-ray. Right? The pain went away, I got better, I could run, I could stretch, I could kick, I could do anything, but if I landed on my side, I was in absolute agony. So some months later, go to another doctor, he says, I think it's a stress fracture. You, from diving on your side so much, I don't know, I was a skinny 20-year-old, you're from diving on your side so much, you've gotten a stress fracture. Also seemed like a really reasonable diagnosis. He said the test is we're going to do a bone scan and we'll see if there's increased uptake around that bone. And so, you know, you get this little skeleton that comes out of that test, and sure enough, big dot right there. And he said, yep, it's a stress fracture. Put me on crutches. I spent a lot of my third year at university on crutches. Still didn't get any better. Went back to the initial doctor in the city where I was going to university, who had thought it was a groin pull. He takes another x-ray. He said, I think it's a bone tumor. He said, it's not a kind that'll grow. He said, and the fact that you've had it for a year and it's still hard to tell is a really good sign. He said, I think it's an osteoid osteoma, which is a type of bone tumor that it's vascular, it's inside the bone, and it just gets denser and denser. It can hurt like hell. And I said, you call my mother and explain this to her. But so then we went to a surgeon to make the final diagnosis. And I remember he said, so all of this, there's confirmatory bias. Nobody was stupid and no one wanted to not help me. Right? And they were all going with reasonable assumptions given the situation. An osteoid osteoma is a really rare thing, right? especially for a soccer player who's come off the field, who's throwing herself on the ground all the time, right? There's a lot of orthopedic explanations for pain before you get to bone tumor, right? So, but when I went to the surgeon who, eventually took care of everything, and I'm still playing soccer today, but I remember he asked me, I bet you when you take aspirin, it feels a lot better. And I remember thinking, and I said, yeah, right? Because I don't want to be rude to the doctor. And he seemed so sure. And the reason he asked that, because it's a vascular tumor. If you take anything that thins the blood, it releases the pressure, and so you have less pain. But again, that was and he was brilliant, and he saved me, and I'm still playing. He's probably gone now because he was pretty old at the time, but I wish I could tell him I'm still playing soccer thanks to you, right? He moved the muscles around, he got the bit of bone out, and I was fine. But such a confirmatory question, right? Right? He could have just asked, have you noticed anything not even asking about aspirin. He could have said, what makes the pain better? When it hurts, is there anything that makes the pain better? And then waited to see if I said, boy, aspirin works like a charm. Then he could say, tick. Now, there are other things that aspirin will help too, so it doesn't, completely solve the problem. But at least then he's got a consistent piece of data, right? But asking, I bet it gets better when you take aspirin. And I think when we treat patients, we always have the motivation that they're getting better. And so we may ask questions that encourage them to say things. Or if we're particularly worried about them and we think they're getting worse, we may ask questions that bring about answers that confirm what we're already thinking. So that's a real issue, is confirmatory bias. So what can we do? We need to try really hard to search for both confirming and disconfirming information. We need to ask ourselves, if I'm wrong about this, what do I need to look for? If it's the opposite of what I think, or if it's this other thing, what test do I need to do? What question do I need to ask? And that runs into this second one. Try and entertain multiple hypotheses. If you arrive too quickly at an initial diagnosis, be aware that you may end up feeling really right about that because of confirmatory bias. Right? And that entertaining 2 possibilities or 3 possibilities, early on at least, is a great way to get around confirmatory bias. Play devil's advocate with yourself, or have a colleague play the devil. What if I'm wrong about this? And there's something called a premortem. So we all know what postmortem is. Things go very, very badly, and then we sit around and try and figure out why, which is a really good process to have. But a premortem is, before you make the decision, imagine it goes very, very badly. Why will that be? What would it be that I have missed? Or what side effect might have caused that? And that's a premortem. And that doesn't mean that we don't ever do anything, that we don't treat people or whatever, but it just has us, having in our mind, what do we need to be considering or thinking about or ready for? Because we tend to assume that the decisions we make are going to turn out well, and then go through a confirmatory process.